This is my patient, Angela. The first assessment I'm going to do is a respiratory assessment, and then I'm going to do a cardiac, and then I'll do a GI with an upper and lower extremity assessment. So typically I would be entering my patient's room. She wouldn't be back towards me, but in this purpose, she's going to be from the back. I'm going to start first. So first I want to assess her respiratory. What is her rate, her rhythm? Is she using any accessory muscles, intercostal muscles? What's her position? Is she in a tripod position? Is there any visible pulsations? So does she appear short of breath? What is her skin color? First I would want to do a palpation posterior. I would want to check for the bottom of her lungs. I'd be placing, and this is checking for expansion of her lungs. So at the bottom I place my arms around the lower lungs, and I ask her to take a deep breath in and out. And I would be checking to see if both sides are symmetrical and rising evenly. Then I would want to palpate both anterior and posterior. Is there any crepitus? Is there any masses or lesions? And again, I would want to do this anterior also. And then I would want to palpate for tactile fremitus. And to do this, you want to palpate in between the intercostal spaces. With the palm of my hands, I would be checking for vibrations. Is there normal vibrations in all areas? Is it symmetrical? Is it high pitch, which could be consolidations? Is it low pitch, which could be possibly an obstruction? So in order to do this, again, I use the palm of my hands, and I ask the patient to state 99,
99,
99,
99,
99,
99,
99,
99,
99,
99,
and 99.
99.
Okay. Then I would want to check for Goffney, which to do this, you have the patient state E, and I auscultate through each lung field. If it sounds like a muffled E, that is normal. If it sounds like a muffled A, that would be abnormal. And you're checking again for is right the same as the left, and more of an A sound could possibly be a consolidation or a mass. So I would listen from top to bottom. And when I tell you to say A or E, say E. Say E.
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 And E.
E.
Okay, so that would be normal. And then the next thing I would want to auscultate through anterior and posterior. First I will do posterior. I'm checking for, first in the back I would want to check vesicular. So in the periphery of the lung I want to check anterior, posterior, and lateral. The bronchial would be anterior, and that would be more of a high pitched sound. Inspiratory and expiratory would be equal in length, and that would be her best over the thorax or the larynx. Bronchiovesicular is her best in the second intercostal space, and that's more of a medium pitch. And then the vesicular breath sounds are heard best at the bases, both lateral, posterior, and anterior, and they are more of a low pitched sound, where inspiratory is greater than expiratory. So first you want to listen with the diaphragm of your stethoscope, listening from top to bottom, side to side. Are the lung sounds clear? Are they equal? Is there any wheezing, crackles, rhonchi? Are they coarse? Are they diminished? So you want to compare it. So take a deep breath in and out. 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 And a deep breath in and out. So typically then I would just walk around and do my anterior assessment, but since we're doing a video, I'm just going to have my patient turn around. And again, I'm going to inspect the anterior chest. Is there any crepitus? I'm going to palpate. Is there any masses? Are there any lesions at all? Are they using any intercostal muscles to breathe? Are they in a comfortable position? I would want to assess for bronchial breath sounds, again, in the thorax or larynx area, and then more of a high-pitched breath sounds. And then I'm going to assess bronchial vesicular in the second intercostal space, right and left, and vesicular in the periphery, anterior and lateral. Take a deep breath in and out. 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 Deep breath in. And if they have larger breasts, you can ask them to hold their breasts out while you do your lateral assessment. Okay, so next I'm going to have the patient lie down. We're going to do our cardiac assessment. Okay, first in order to do a cardiac assessment, are you close enough that you can see? Okay, you want to check for precordium for pulsations. The PMI, which is the apical impulse, that is her best over the fifth intercostal space mid-clavicular line. You're checking for a thrill. So again, you're just going to use the palm of your hand, feeling over the chest and down through. And then you want to auscultate in the 5 oscillatory regions, which is the apical and the pulmonic, which is her best in the second tricuspid area. The Erb's point, her best in the 3rd intercostal, and the tricuspid in the 4th to 5th intercostal, and the mitral, which is the 5th intercostal mid-clavicular line. You want to listen for the rate, the rhythm. Are they having extra heartbeats? Does it sound normal? You want to listen with your diaphragm and your bell in all 5 areas. S1 is her best over the tricuspid and the mitral valve closure, and that is more the apex of the heart. S2 is her best over the aortic and pulmonic valve closure, and that is her best at the base of the heart. Then you want to assess carotids. In order to assess carotids, you want to assess right and left at 2 separate times because you don't want to palpate both because you don't want them to cause a vagal. You don't want to cause a vagal episode. So in order to do this, you ask them to take a deep breath and exhale, and then you want to auscultate, and you also want to palpate. You're checking for a bruit and a thrill in the mid to lower carotids. So first, you're going to take a deep breath in and out. I guess that would be more necessary when you're auscultating, but. And then you also want to auscultate, and then you want to do the same thing. Take a deep breath in and exhale and hold your breath. Good. Okay. So again, if you hear any murmurs, especially a mitral murmur, you would want to have the patient lie on their left side, left lateral side. So maybe we can just have you put your head down that way. So slightly on the left side, just not as, yeah, right there. And then bring this arm across. Just have you relax like that. Don't fall. So in order to hear a mitral murmur, it's best to listen with both the diaphragm and the bell, but bells listen to murmurs better at the apex of the heart. Okay, good. All right. Then I'm going to do my next assessment on the abdomen, so you can go ahead and get back into your comfortable position on your back. Okay, and to do an abdominal assessment, first, are you having any pain? You want to look at their abdomen. You want to pull their shirt up. I'm going to look at their contour. Are the quadrants symmetrical? Is there any masses or is there any lesions? Is there any skin issues that should be noted? You want to auscultate in right and left upper quadrants and left and right lower quadrants. So I'm going to do that first. And that is with your diaphragm. You also want to auscultate the aortic artery, the right and left renal artery, and the right and left iliac artery. So the aortic is in this area, your renals is in right and left, and your right and left iliac is in this area. And that is best heard with the bell of your stethoscope. And you want to assess for any bruits. It could be related to some high blood pressure or stenosis. And next, you want to palpate the abdomen. So, is there any pain, rebound tenderness, any masses that you feel for? And you want to make sure. You can do a light palpation or a firm palpation. Okay, so then I'm gonna assess your upper extremities and your lower extremities next, so just put your arms to your side. So in order to assess your upper extremities, you want to look at their skin. Is there any ulcerations, any bruising, skin breakdown? What's their hair distribution like? You also want to assess, do they have any edema, any change in sensation, any numbness, any tingling? You want to assess the pulses, which I'm going to actually, just so he can see, I'm going to put your arm up here. So first you want to assess the radial pulse. And to assess a radial pulse, you want to check, is it 0, is there no pulse? Is it +1, which is a weak pulse, +2, which is normal, +3 is increased, and +4 is bounding pulse. And you want to assess 0 to 4 in each area that you're checking a pulse. So first would be radial, and that's a +2. And then we would check an ulnar. And then you would want to check for a brachial pulse. And you want to do this on your right and left upper extremities and your right and left lower extremities. And you want to look at their nails, the shape, the color. You want to check for capillary refill. And she has normal capillary refill. Any change in color as well. So you relax your arms, then we'll do a lower extremity assessment. And as well as upper extremities, you want to check for any edema. Is it pitting? Is it non-pitting edema? You want to look at their skin color, any skin breakdown, any lesions, their hair distribution, anything that seems abnormal, any change in sensation, numbness, or tingling. You want to check for pedal pulses, and it's best if you flex it here and then check pedal pulse. And that again, +2. You want to check a posterior tibial pulse. So she stays in a relaxed position. Just make sure you're getting close enough so they can see where I'm checking. Okay, posterior tibial is a +2. And to check a popliteal, I'll have you bend at the knee. And you want to put your arms or your hands around using all 4 fingers to best assess it. And then I have a +2 popliteal. So all pulses are +2 and normal. And that concludes our assessment.